injection.
The CGRP diagnosis.
So our panel, of course, is Dr. Chopra and Dr. Henderson. My name is Amanda Ikolola. I'm the president of the Dysautonomia Support Network. And thank you all for being here. We're going to take questions. And if you'd like to ask a question, please just raise your hand and I will do my best to get around to you. Okay, I'm going to start here. If you can stand if you'd like.
Hi, I'm Barbara. My question is for you, Dr. Chopra, because I was listening to everything you said. I'm going to try and make this a question. My son started at gastroparesis and then progressed to POTS and then small fiber neuropathy. The small fiber neuropathy is what I thought we were battling the whole time, and I was told it can be patchy. His pain is all around his abdomen. I never heard of MALS before, but that's all what he seems to have. So where do I go to find someone who knows about it that can help me get him treated?
Well, I mean, you said he has gastroparesis, POTS,
Dysautonomia.
and did you say mast?
No, not that I'm aware of.
Okay. So
Small fiber neuropathy.
And is his belly pain really intense belly pain?
Yes, it's all the time, but when he eats, it's 10 times worse. And he actually tries not to eat so that he can do things.
So there are only very few surgeons in the country that do this surgery. The person I send my patients to is Dr. Richard Su at GSU. He's in Connecticut.
And what kind of doctor is he?
He's a vascular surgeon.
Okay.
That's surgery.
Thank you, thank you.
It's a surgeon.
Okay. Sorry.
Okay, hands again, sorry. Okay, I'm gonna go there and I'm gonna come back because we've got a lot on this side. And that was an excellent presentation. Thank you both for taking the time, and I challenged Dr. Chopra to write this presentation. He really did an excellent job, so thank you for doing that for us. I think we all, with connective tissue disorders, really think a lot, really spend a lot of time thinking about subluxations and the experience of dislocating, but I wanted to really get a good education about neuropathic pain, and he did a great job. You're gonna have to come to me, sorry. And some technical difficulties.
My question's for Dr. Chopra. I'm Crystal. Small fiber neuropathy is actually a brand new diagnosis to me, and I was speaking with my neurologist about it, and I asked her about autonomic neuropathy. And she said, if you had dysautonomia, that was autonomic neuropathy. Are they indeed two separate things? And I have a POTS specialist, but do I need to do something like go back to Vanderbilt for?
I mean, if you have small fiber neuropathy, is this the microphone?
No. This is the only one that's working right now.
If you have small fiber neuropathy, and there's a suspicion that you might have autonomic neuropathy, you have to look at the unifying diagnosis. There has to be something that's connecting the two. Diagnosing autonomic neuropathy, they can do orthostatics, like they can do a tilt table test, or they can do some check your blood pressure, heart rate, like they do for POTS. And if there's a suspicion for that, then you have to look for unifying diagnosis, and it could be one of the autoimmune conditions. So that's what you'll have to look at.
So dysautonomia and POTS and autonomic neuropathy are different diagnoses.
Kind of, yes. Yeah.
Kevin?
My name's Kevin. I was wondering whether sub-Q IgG would have the same effect as IVIG in the neuropathic pain, in your experience?
Kevin, I don't have a great answer for that question. This is a little something an immunologist should be able to answer. I don't, unfortunately, I'm not that up to it on these things.
This is fun.
Get your exercise.
Yeah.
Dr. Chopra, my neurologist told me that in order to have small fiber neuropathy, you have to have large fiber neuropathy. Is that true?
Hi. I have EDS, dysautonomia mast cell. Both my parents are now diagnosed with Parkinson's disease, and I was wondering what the involvement of the orexin and the hypercretin system are in dysautonomia and in pain.
I'm sorry, you said what system?
Orexin.
Oh, I see. Not that we know of if there's any relationship. Both your parents have Parkinson's?
And my great uncle did too.
From your father's side? Are you worried that you might get it?
Oh, yeah. A little bit.
Yeah,
I don't have it yet, though.
it's hard to answer that question. We don't know. We don't know enough between the relationship between Parkinson's and EDS and mast cell. There's nothing that we know of.
Yeah, and I didn't know the orexin system specifically, since they seem to feed into the Parkinson's disease and the pains and even like dysautonomia stuff. Like, is there much knowledge about it?
No.
Henderson, do you have anything to add on that?
My question was for Dr. Henderson. I was curious if you were aware of any research that's being done now on sort of the intersection between craniocervical instability and some of the physical issues around the brainstem and idiopathic intracranial hypertension and the sort of the connections there or, in this EDS population.
Well, I'm not aware of anyone doing research in that specifically, but if you have craniocervical instability, then that can interfere with your CSF flow from the intracranial compartment into the spine, and that can exacerbate pseudotumor cerebri. It can also interfere with the venous flow, and when we're lying down, most of the venous flow from the brain passes out through the jugular system. And if you're standing up, there's a little bit more blood that comes down the perivertebral plexus, so that craniocervical instability, I think, can exacerbate venous flow out of the brain, and that can also increase your pseudotumor cerebri. And then there's the association of, if you have EDS and craniocervical instability, a lot of those patients seem to have increased intracranial pressure. They're more sensitive to it. They also increased incidence of thrombosis, hypercoagulability, and maybe also congenitally small or developmentally small venous sinuses draining but so there's a proclivity in that population to have that problem, but I'm not aware of anyone working on it. Right.
I have two questions. One for Dr. Henderson is about the importance or the role that Tarlov or perneural cysts might play in pain. And then the second was to Dr. Chopra. You didn't mention central pain syndrome at all. And how does that fit into this? Because people are discussing that.
Concerning the Tarlov cysts or the perineural cysts, they were discovered by Tarlov. They occur in about 3% of the population, but most of them are very small. Sometimes the Tarlov cysts get very big, and of the big ones, I would guess that maybe a half or a third of them cause pain. And they cause pain and sensory loss and urinary difficulties because they mostly occur in the sacrum, about 90%. Sometimes they occur in the lumbar and even thoracic spine and cervical. I wrote a paper on Tarlov cysts, and then I saw every Tarlov cyst in the world, and it almost ruined me. But since I began learning about EDS only a decade ago, I found that a good number of the Tarlov cysts arise in the EDS population. So they have a weakness of the collagen and therefore a proclivity to developing the cysts. However, I don't think I've seen any Tarlov cysts with CSF leaks. And but some of them can be extraordinarily painful, and the surgery is very helpful on 80%.
So what do you classify as big?
Oh, well, anything 2 centimeters would be big, but they can get up to 6 centimeters. And of course, I have some that are bigger, but they're not Tarlov cysts, they're actually meningoceles, which is anatomically slightly different. Does that answer your question?
Oh, yeah.
So the question was central pain syndrome.
Yes.
Is that you're talking about post-stroke pain?
Well, so a lot of people talk about that as, I guess, more injury related. I think versus central sensitization or.
So from central pain syndrome that I understand is post-stroke. So some people after having a stroke develop this intense pain in an affected side, even though there's nothing going on in that limb. But
she's raising, maybe I have the wrong term, chronic regional pain syndrome.
Yeah. So complex regional pain syndrome is a whole different animal. So the question is.
Right. So how much of this might be injury related, just due to the fact of all of this hypermobility disease?
You mean you're talking about complex regional pain syndrome, CRPS? Okay, so CRPS, we really don't know why an injury triggers CRPS in some patients. We don't know the reason. And it could be anything minor like a small foot sprain to a surgery. And why somebody, the same patient may have had 6 surgeries and had no problem, and then the 7th surgery they developed CRPS. We have no explanation why they do it. And they're now starting to look at the genetics of it to see if there's anything genetically they're predisposed to.
Stand up and move your chair because it's just on.
Sorry, you guys were the lectures I wanted to see the most, and then I didn't because I was put down on very post-drome, so forgive me, but I don't know which one would be better to answer this question. I have POTS and EDS, and a new pain doctor wants to try facet injections in my neck to help with neck pain and potentially the migraines and stuff that goes down my shoulder. But I wondered if that was a appropriate treatment in EDS and how that might affect the effectiveness or whether it would actually make things worse.
So the question that she asked was that she's been diagnosed to have facet joint syndrome in the neck, which facet joints are tiny joints in the spine. They go all the way from the neck to the lower back. And that's the other reason we are so flexible. Our spine is so flexible. And her doctor thinks that he should inject a little bit of steroid into the joint. Is that right? Yes. Yeah. It all depends on. I don't really recommend steroid injections in EDS, but like in one of my slides I mentioned that in certain cases you can try it to a point, like for example, the joint, the idea of doing a steroid injection into a joint is because the joint is inflamed and you put in some steroid, the inflammation subsides. But then you have to find out why is the joint inflamed? Is it hypermobile and is it getting inflamed? So the question would be, for example, in your case, if the joint, so the facet joint is inflamed, yes, they can do a steroid injection, but they also have to find out if that joint is hypermobile, if you have any instability there or something like that, then that has to be addressed. And that's so for the time being, yes, you can do that, but the real what's broken here might be the instability there that needs to be fixed. Or it could be nothing, it could be just some inflammation in the joint and a steroid might do the job. But you can only try it like a couple of times and then see if it makes a difference, but don't go too much into it. The amount of steroid that they use in these joints is extremely small, it's really tiny, so it doesn't really have a systemic effect.
How can they determine from this hypermobility there that may be the issue?
That's again a whole different, so that's actually Dr. Henderson.
The DMX films, digital dynamic fluoroscopy, are very helpful in looking at dynamic, and looking at instability in the neck. And if you get an MRI lying flat, you can be completely unstable and the MRI can be completely normal if you're lying flat on your back. If you get an upright flexion extension MRI, you can pick up a lot of instability in flexion and extension, but you're going to miss the instability in lateral neck tilting and rotation. And so the DMX films, and unfortunately there are not many people who do them. Kevin Lasko does them up near Lancaster, and he does a superb job. And they do show instability in the facet joints with rotation and flexion extension, lateral tilting. I think the facet blocks are good without steroid as a diagnostic measure. If you inject the joint and the pain goes away, then you can say, well, the pain's coming from that joint. Then you should repeat it to confirm your result. And if you can't make it better with physiotherapy and neck brace and seeing Dr. Chopra and so on, then surgery is the last possibility. But it's a good diagnostic maneuver. But I agree that it's probably not a reasonable treatment.
Can I ask one more follow-up to that? With x-rays, can you determine whether there's a cervicocranial insufficiency? Because I have one, they did x-rays doing different tilting maneuvers and felt that there was not instability based on the x-ray.
Okay, well, you can make measurements and determine whether there's radiological instability. But what's important is that there's some people who have, horrible radiology. They meet all the requirements for neurological instability, but they may be neurologically intact. So the true definition of craniocervical instability is not only radiological instability, but there's neurological instability. So you have to clinically make the diagnosis based on your symptoms and the neurological findings, and then confirm it with congruent radiological findings. And that equals the true craniocervical instability, or whatever instability you're referring to.
Hi, I'm Maureen. I think this is for Dr. Chopra. With CRPS, I'm wondering, after a bout of CPRS and release the nerve that might be impinged or whatever it is that's causing, in my case, I had a nerve released and my CRPS eventually resolved, like over a few months, but that was the beginning of it. But I was ending up with small fiber neuropathy that's for the last 25 years. So I just wondered, is that common to have the damaged nerves continue to be damaged even though the acute pain dissipates?
Is the small fiber neuropathy the same area as the CRPS?
It's spread. It has spread to my hands, but it started at my feet. I had CRPS. It's sort of rare, but I had it all feet.
So you had CRPS in both feet and both hands.
Eventually. No. That didn't spread. The acute phase was probably like 3 or 4 months.
So the nerve entrapment that they released was which nerve, which limb?
My lower back and lumbar region somewhere is what I had. It was a chiropractor who released it in some way. I mean,
Oh, it wasn't a surgical.
It wasn't surgery.
Oh. So when he did that, your CRPS improved? So it's, I mean, a couple of things could be happening. I mean, you might be having the same instability or whatever that was causing the impingement coming back, or else you have a completely different condition causing small fiber neuropathy.
I forgot to ask. So, in addition to all the others in the small fiber neuropathy, Matthew twitches, jumps. He was totally unaware of it, but as it's kind of gotten a little bit worse, like he thinks he's sitting still and his legs just keep jumping. I've mentioned it to the neurologist and was told that it was chorea. No clue. But is that something you see with either small fiber neuropathy common or MALS, or should I be looking at something else, do you think?
Okay. So the question was that he's having twitching in his legs, and he has been diagnosed with small fiber neuropathy.
Correct.
Small fiber neuropathy doesn't affect the motor nerves. Now, but the unifying diagnosis would be if there's something that's affecting the small fibers, is that also affecting your other larger fibers or the motor fibers? That would be what you need to look at.
He had biopsy, no large fiber neuropathy, just small fiber, no cause was found.
Right. So, one of the things that they've seen, studies have shown that these people with severe neuropathic pain eventually develop low dopamine levels in the brain, and so supplementing that would make a difference. So there's one drug that I like to use is called Cinemet. It's an old drug used for Parkinson's. It's approved for Parkinson's, and that kind of increases your central dopamine levels, and that can happen. That can help. Preferably take it when he's starting to have the twitches. But if you think if they're all the time, then you can go on a routine basis.
I'm going to ask a question real quick to Dr. Henderson. I hear this question a lot, and I just wanted to get your opinion about the prevalence of head injuries, awakening symptoms in patients that may have Chiari malformation but are functioning and not having migraines or any paresthesia or any real problems that are functioning. We know that people can have Chiari and function pretty well, and others struggle. So we also see in dysautonomia that sometimes a head injury, like an RSD, can be the onset of the symptoms that often become disabling. So, where do you see that there's a certain type of patient that has this event that happens, or is it just across the board? Is this something that you have any comment on? Has anybody studied it to really get any kind of data?
Yes, they've studied it.
Okay.
Because this one comes up a lot in our patient group.
So Chiari malformations occur in about 1 in 100 people, and most of them are probably non-symptomatic. However, following an injury, many of them become symptomatic. And there was a study, a radiological study, and they looked at, I think, 1,200 MRIs, and 600 of them were after trauma and with post-traumatic injuries, and 600 did not have leg pain. And of the patients who had trauma, the incidence of Chiari was much, much higher, and the incidence of those people having upright MRIs was even higher again. And the conclusions of that study are that maybe those people were walking around with Chiaris all the time, and then the trauma made it symptomatic. But the data would suggest that maybe they had a proclivity, and the trauma made the tonsils descend another 4 or 5 centimeters. So certainly Chiaris become more symptomatic, and it may even happen following the trauma. But also in EDS, a lot of patients with craniocervical instability have Chiari-like symptoms, but the symptoms are really due to the instability, not the Chiari. So I would say the majority of patients with very small Chiari and craniocervical instability, in those patients, the symptoms and deficits are due to the craniocervical instability. And that was suggested by other papers where they found that the compression of the brainstem came from the front, the odontoid, not the Chiari malformation. So the likelihood, I think we believe that certainly there's a spectrum from joint hypermobility syndrome and hypermobile EDS, and the number of people with joint hypermobility syndrome is in excess of 1 in 100. The geneticists say that the likelihood of hypermobile EDS, or the incidence, is 1 in 5,000. That's ridiculously small, but ridiculously small figure. But without a doubt, minor or relatively minor trauma or even infections can bring on hypermobility problems and Chiari-like symptoms.
So would you say that potentially tethered cord could also predispose somebody to having neurological stretching as or neurons being affected, and then having a slightly traumatic or moderately traumatic incident being more catastrophic in its presentation?
Petra
I'm getting a little head
is going to be giving a talk, and she's become the expert on that, but 50% of patients with tethered cord syndrome have suboccipital headache. And so those patients in a hyperflexion injury are more likely to develop more neurological symptoms from that. Have you comment?
So this the data that they have now is obvious carry malformation plus low-lying cerebellar tonsils. That means they don't quite meet the criteria. The untethered cord, there's a 66% incidence of them having people with tethered cord. 66% patients with tethered cord are likely to have a low-lying cerebellar tonsil or obvious carry malformation. On the first part of the question, there was a study that came out from France by Professor Amelie. They looked at brain MRIs in patients who were not symptomatic before a concussion, became symptomatic, and they looked at brain MRIs and all that, and they were able to show that of the 250 patients that they studied, they all became symptomatic after a concussion, major or minor, and they developed all sorts of symptoms of EDS.
So if someone in our patient population gets a concussion, it's not just, we shouldn't assume it's a Chiari that is the issue. We need to look at the neck and potentially tethered cord to rule out all three, not just Chiari malformation, correct?
Right. So it's also become an issue in the medical legal domain where a person gets in an accident and is now literally bedridden, and it's hard to explain to them, like, this can happen. It's very
Thank you. Question? Get through everybody? Okay. Allison.
Hi, I'm Allison, and my question is also for Dr. Chopra. One thing that I've experienced is pain that the best way I can think of to describe it is like a vibrating cell phone, where it'll be like tingling pain off and on. When I talk to other people at PDS, that seems to be relatively common, but when I bring it up with doctors, they generally look at me like I'm crazy. So I was just wondering if that's something you see a lot and what you would recommend in terms of how do you chase down what might be causing that and how to treat it.
Where is this vibrating pain?
It's usually near a joint, so like right above my knee.
I mean, it's hard to kind of explain why this can happen, but it can happen. And it should be just treated as another neurological manifestation of neuropathic pain.
Sorry. Somebody else have a question? Okay, we're at 4:30. One more? Steph? Okay. One more. We're at 4:30. We have some events after this.
My question is for Dr. Henderson. Dr. Henderson, do you find that patients with EDS or related connective tissue disorders that do affect the collagen are more predisposed to that neuronal axon injury that you spoke of earlier with the axon stretching? Can that happen basically without the hypermobility injury? Can it happen spontaneously, or is it always directly correlated with an injury?
So the question is, can the, say, craniocervical or subaxial instability occur spontaneously in EDS, or is it simply an increased proclivity to neural injury following trauma? Right. Well, I think I don't think I can remember anyone. I mean, most patients have some kind of injury, and sometimes it's infections. And I think that that a lot of ligamentous injury gets worse with childbirth and the high estrogen levels. That can cause much greater laxity of ligaments, and so that's not trauma. Some people have, you know, infections and other kinds of disabling conditions that may weaken the ligaments. There's a lot biochemically that we don't know. For instance, the metalloid proteases can be switched on and degrade collagen. And I think sometimes there's thickening of collagen as a result of its weakness. It then thickens and you might speak to this, that the thickened collagen, thickened ligaments may increase the number of entrapment neuropathies we see. So there's a lot of epigenetic phenomena that are happening that we don't begin to understand yet. The good news is that when we do understand that, we may be able to treat that with drugs or other therapy before it gets too bad. You wanna? No.
Okay, thank you very much. Thank you to our panelists for speaking.